If you have a spinal cord stimulator implanted right now, or if your doctor has mentioned the idea, there's a 2015 trial in anesthesiology you should know about. It changed how the FDA labels these devices and how physicians choose between them. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the research that shapes how pain medicine is actually practiced. Today, we're presenting the SENZA-RCT. Spinal cord stimulation, or SCS, is a surgically implanted therapy for chronic back and leg pain that hasn't responded to medication, physical therapy, or surgery. Thin electrical leads are placed in the epidural space along the spinal cord, connected to a small battery the size of a pacemaker placed under the skin. The device delivers electrical pulses to interfere with pain signals before they reach the brain. For decades, this worked by replacing pain with a tingling sensation called paresthesia. The SENZA-RCT asked whether a different approach, higher frequency stimulation that produces no sensation at all, could do better. The clinical question, in plain English, in patients with chronic back and leg pain who are candidates for spinal cord stimulation, does 10 kHz high-frequency therapy outperform traditional low-frequency stimulation at relieving pain? In PICO terms, population is adults with chronic back and leg pain who have failed conservative treatment. Intervention is 10 kHz HF10 stimulation. Comparator is traditional sub-50 Hz paresthesia-based SCS. Outcome is the proportion of patients with at least a 50% reduction in back pain at 3 months. This was a multi-center, randomized, parallel-arm, non-inferiority trial. 10 comprehensive pain treatment centers across the United States. 198 patients with chronic back and leg pain were randomized 1-to-1 between HF10 stimulation and traditional low-frequency stimulation. Of those 198, 171 passed a temporary trial period, the standard SCS workflow, and were then implanted with their assigned permanent system. The primary outcome was responder rate at 3 months. A responder was defined as someone with a 50% or greater reduction in back pain, with no stimulation-related neurological deficit. That second part matters. It means the response had to come without the device causing problems of its own. The trial also tracked leg pain reduction, functional outcomes, patient satisfaction, and safety. Follow-up extended to 12 months, with later publications extending out to 24 months and beyond. Important to flag up front. This trial was funded by Nevro Corporation, the manufacturer of the HF10 device. One of the authors was a Nevro employee. That's a real conflict of interest. The findings are well documented, but the funding source is part of the picture. The headline result: HF10 was substantially better than traditional SCS at 3 months. For back pain, the primary endpoint, 84.5% of HF10 patients were responders, versus 43.8% in the traditional SCS group. P-value less than 0.001. For leg pain, 83.1% of HF10 patients were responders, versus 55.5% of traditional SCS patients. P-value also less than 0.001. The relative ratio, how much more likely an HF10 patient was to be a responder, was 1.9 for back pain and 1.5 for leg pain. Both 95% confidence intervals were comfortably above 1. 2 further findings worth noting. First, the superiority was sustained through 12 months, meaning this wasn't a short-term novelty effect. Later real-world data has extended this durability out to 24 months. Second, HF10 patients did not experience paresthesias. The traditional SCS group did, by design. For patients, that's a meaningful experience difference. No tingling, no positional awareness of the device working, just pain relief or its absence. 3 limitations matter for interpreting this trial. First, industry funding. Nevro Corporation funded the study and had an employee on the author list. Industry-funded studies are not invalidated by that fact, but the result lands with appropriate skepticism. The device maker's trial of its own device showed the device worked. Second, the comparator was older generation traditional SCS. Newer waveforms developed by other manufacturers, burst stimulation, differential target multiplex stimulation, closed-loop systems, have come out since 2015 and weren't tested here. So HF10 beats traditional doesn't necessarily generalize to HF10 beats every modern alternative. Third, the trial enrolled patients with both back and leg pain, with leg pain at a specific intensity threshold. Patients with isolated back pain only or isolated radicular pain only were not directly studied here. So what does this mean in practice? First, the regulatory consequence. Based on this trial, the FDA gave Nevro's SENZA device a superiority labeling claim, the first SCS system to carry that designation. That's a real regulatory event with downstream effects on how the device is marketed, prescribed, and reimbursed. Second, the paresthesia-free element matters more than it sounds. For some patients, the tingling sensation of traditional SCS is a positive feedback signal. They can feel that the device is working. For others, it's intrusive, especially at night or in specific postures. A paresthesia-free option gives physicians and patients a meaningful alternative. Third, this is one trial in a fast-moving field. Newer device platforms from Abbott, Boston Scientific, and Medtronic now offer their own non-paresthesia-based waveforms. Today, there is a wide range of waveforms that continue to be studied, including burst stimulation, differential target multiplex stimulation, and closed-loop systems, and the relevant choice during a patient's SCS trial is often between several of these. Fourth, this trial does not tell us which patients respond best to which waveform. SCS response is heterogeneous. Two patients with seemingly identical chronic back and leg pain can have very different outcomes from the same